Good afternoon, everyone, and welcome to Tackling Your Prostate. I'm Brian Goodman, WPA's Director of Large Corporate Business. In the latest of our ongoing series of health and wellbeing webinars, we're here today to learn a little more about men's prostate health and problems. Not only because I'm a male and of a certain age, where such things are becoming regretfully more of interest, but also because our health is so important to productivity and wellbeing in the workplace. The fact that half of men over the age of 50 show signs of prostate enlargement, and that there are things that we can do to mitigate the impact, underline why the next 45 minutes will be so important. We're honoured today to be hearing from Ben Challacombe, who is a leading urological surgeon at Guy's and St Thomas's Hospital. Ben's areas of interest include benign and malignant prostate disease, and minimally invasive surgery for the upper urological tract. Ben has performed over 2,000 robotic procedures and specialises in partial nephrectomy and radical prostatectomy. He's the trust lead for clinical robotics and runs the International Robotic Fellowship Programme, teaching robotics and holmium laser prostatectomy at British, European and World Annual Urology meetings. Before I hand over to Ben, there will be time for questions at the end. If anything springs to mind in the next 30 minutes, please click on the questions tab in this window. If the window's not there, please click the white arrow on a red background and it should appear. Over to you, Ben.
Brian, thank you very much. Sorry, it wasn't meant to be a tongue twister doing the introduction of all the medical words. But hello, everyone, and welcome, and thank you very much for having me along. I'm going to tell you in the next half hour or so, before we have some questions, really about prostate disease, prostate cancer, benign prostate enlargement, and how this presents to doctors, how it presents to patients, and what you might want to do about it. So here we have a picture from John Hunter from 1750, who had already worked out that a lot of problems come from the enlargement of the prostate. So there are two main charities who are involved with prostate issues in the UK. It's Prostate Cancer UK, who get the Movember money, who I work with and closely, and there's the Urology Foundation, who I am a trustee of, and who are an excellent charity looking into specific research for prostate diseases. Now, this has become quite topical in the last year or two, mainly because of this chap, perhaps, and this chap, Stephen Fry and Bill Turnbull, who have both had significant prostate cancer and talked about it. And linked to those two events also was for the first time UK prostate deaths overcame UK breast cancer deaths. So that all kind of happened at the beginning of 2018, and I think that we've been up the agenda a bit more on the prostate world since then. So the issues we're going to talk about are an overview of prostate diseases, who should be checked, when you should be checked, what are the signs and symptoms of prostate cancer, the diagnosis, the treatment options, and the enlarged prostate and what you might want to do about it. There's an interesting national audit, of which I've sort of taken out their little infographic on, but really the take-home message are that there's 52,000 men a year now in the UK are diagnosed with prostate cancer, sadly, and that has gone up quite a lot in the last few years, probably due to increased awareness. But on a good side, far fewer men are presenting with metastatic, i.e. advanced disease. That's only 13%. So we're finding more men, but we're finding them at an earlier stage, and therefore the cure rates are obviously higher. And we're doing a whole lot of other things to try and improve outcomes in terms of how we biopsy and how we treat men, and we'll come on to that. Now, I don't like talking about COVID because it's ruining everybody's life. You've all been probably in home for a year. I've been in the work more than I've ever been in work, and what we've found is there are men missing, many men missing. We've only diagnosed half the amount of men with prostate cancer than we should have done. So the orange is where we were in 2019, and the blue is kind of post-COVID. And the only other cancer that's had such a drop is, of course, lung cancer, because if you've got a cough, nobody's interested in having a look at you at the moment. They tell you to come ring back in 4 weeks. But for prostate cancer, it's also bad. You're not getting in to see the GP and having those casual chats about family history or risk factors or awareness and those sort of low-level case-finding discussions. So a bit of GCSE anatomy for you. Side view of the pelvis of the male. You will see the bladder. Then underneath the bladder is the prostate, and the prostate is like a donut underneath the bladder, and you pee. The water pipe goes through the middle of the prostate, and at the back of it are the sperm ducts, and they come through the middle of the prostate as well. So it carries the urine through it, and it makes a lot of the fluid that is in semen, and then that comes out through the urethra. The other view here is sort of front-on view, and again you will see the bladder there with the urinary openings, the urethral openings, and then you'll see the prostate has this area through the middle of it, the urethra, and the urine directly goes through that before it's sort of held in check by what people call the pelvic floor muscles, or the membranous urethra, or the external sphincter, or all those terms are kind of interchangeable. So some facts. It's a prostate. I think it's about 50-50 people come in and say that they've got a problem with their prostate. Prostrate is what I do when I ask them to lie down and examine them. Prostate is what they have. All prostates grow as men get older, pretty much. The only other thing that I'm aware of that grows in men as you get older, I'm sorry, chaps, is your ears. The risk of an enlarged prostate and prostate cancer are not linked, as in just because you have an enlarged prostate, you are no more likely to have prostate cancer than if you didn't have an enlarged prostate. So they're not linked, they're both common, and you can have both, or you can have one or the other, or none. Worsening urinary symptoms are usually due to enlargement of the prostate rather than cancer. So prostate cancer usually doesn't cause many symptoms because prostate cancer grows on the outer part of the prostate, and enlargement happens on the inner part of the prostate, and the inner part is the part that squeezes the pipe and causes your symptoms. So before we get on to the sort of interesting gory bits and some videos and bits and pieces, let's just think about how do people come to be discovered with prostate cancer. Well, there is the rather polarizing PSA blood test, and we'll come on to that. So that is a blood test that can be drawn just as a simple blood test and can tell you a risk that you have prostate cancer. It is not specific to prostate cancer, but it is specific to the prostate. So it is therefore not the world's perfect test. It's not a great tumor marker, but it's a start. Family history puts your risk up by twofold. If your father or uncle or brother have had significant prostate cancer, if you're Afro-Caribbean background, that will put your risk up by twice as well, roughly. Slightly higher risk if you're obese. And then we come down to people who have urinary symptoms. They're often checked for prostate cancer, which may or may not be due to their symptoms. And of course, people with more advanced disease, you've got bleeding and other troubles, bone pain and weakness and loss of weight and anorexia and all of those things, which often sadly signify a more advanced disease. So let's look at the PSA, the prostate-specific antigen, or the promoter of stress and anxiety, as some people would call it. This is a tumor marker. It's raised in BPH, which is enlargement. It's raised if you have an infection, and it's raised in prostate cancer. So it's what we call a sensitive test, but in statistical terms, it's not a specific test. It's quite useful if the prostate's been removed or treated, because then it can be used because it should be 0, and then it's quite useful in that situation. But often it's only the starting point for our investigation. What does it do? Well, it kind of breaks down the semen, allowing the sperm to freely swim, so you need it, which also means that you shouldn't ejaculate in the first day or in the day or two before you have a PSA blood test, because it might be just higher because of all of that. And we think the reason is that the cancer tends to just sort of leak out more PSA, and that's why your PSA level goes up a bit if you have prostate cancer. So there are values, and it depends on how old you are. And the reason it depends on how old you are is as men get older, you allow them to have a slightly higher PSA because their prostates are generally slightly larger. So you don't normally test this before 40 because it's almost unheard of to have significant bad life-affecting prostate cancer before 40, unless you had all the risk factors So at age of 40 to 49, it's 2, and then up to 50 and 59, it's 3, and 60 to 69, it can be at 4, and then over 70, it can be, depending on where you are in the country, 6 or 8, or some people are even trying to make that a little bit higher. So the starting point, if you're, say, 45 and your PSA was 2.5, that would be abnormal. And if you wanted one figure for all men under 70, people often use 3. So we don't have a screening sort of program throughout the UK for prostate cancer. And people say, well, why is that? Or the patient groups say, why don't we have a screening group? Because it's never been proven that this is going to cause, in a huge population, more good than harm. So if you're going to have a PSA test, you should remember that it could find just that you've got an enlarged prostate. It may put you through a lot of tests which are not entirely pleasant. But before having that blood test, you should, as we said, not have ejaculated, not have gone on the cycle at home or vigorously gone to the gym. You obviously should not have had a biopsy or a significant examination of the prostate or a urine infection, I would say. So this is how people often think about it. It's not that bad. I mean, it's easy for me to say, but it's a literally 20-second job. It's not painful, and it tells the doctor quite a lot of information about the size of the prostate and whether you actually have an abnormality on the edge, because the part of the prostate you feel is the part of the prostate that cancer grows in. What is a nicer way is to have an MRI scan, and this is a picture of an MRI scan of a normal scan, showing a lovely white outer part of the prostate and a big inner part that has grown with the orange, with the gold ring, meaning the urethra, the water pipe through the prostate. Now, in a prostate cancer, you get a large black blob on the outer part of the prostate. If it is a sort of medium-sized cancer, you might have nothing to see, or you might have even worse than that, where you have bigger blobs that sort of go through the whole of the prostate. So this has kind of become, after the PSA test, the new gold standard is to get what's called a multi-parametric 3T, which is the size of the magnet MRI scan, to look at what's going on. And you need to get someone who looks at these all the time, thousands a year, to report it and give you an opinion. And then if you were to find a black blob, then what you would do is, in my view, you should only have a transperineal biopsy, which is a biopsy that goes through the skin, as opposed to the way we used to do it for about 30 years, which is a transrectal biopsy, which you don't need to be a doctor to work out that if you put a needle across the rectal mucosa, that you've got a higher risk of infection and potentially bleeding and other things. So we do that, and then we get an answer as to whether the prostate cancer is localized, how bad it is on a grading scale of how bad it is, and I'll come on to that. And then we start talking about how to treat it. So just to harp on again, because this is, I suppose, the key thing is to remember about all of this is it is common. You've got a 1 in 8 lifetime risk. So if there's 300 people who are watching this or interacting with us today, 1 in 8 of you have the lifetime risk of prostate cancer, which is quite a lot. The average age of diagnosis is 65 to 69. So if you're 42, the chances of you having this are still quite low. 2 times risk of family history. If you have BRCA genes in your family, that also puts you up. So this is an infographic sheet from Prostate Cancer UK, and it's 1 in 4 for Afro-Caribbean black men. So if you're a black man with a family history, you definitely need to be thinking, I should be getting checked, because that the risk then goes pretty high. So to give you some background about what we sort of feel in urology about screening is that in Gothenburg in Sweden and in a lot of the Scandinavian countries, bizarrely their rates are a little bit higher than the rest of Europe. They've done a great study, and they show that if you're going to live 10 years, then you probably get some benefit from screening. So you wouldn't screen someone who's 82, who's had a stroke and a heart attack in a wheelchair. That would be ridiculous. It's probably not sensible to start just randomly screening them. But if you are a young, fit man with no other major medical problems, who doesn't smoke perhaps, but although that is contentious, then it's probably sensible to get tested. And most private health systems would put men over 50 through a PSA test. Why the issue? Because previously we didn't treat prostate cancer very well. We over-treated people with lower risk disease. Their treatment was full of complications. But in 2021, we've got this MRI, we've got this biopsy, we've got better treatments, and we think we've got better outcomes. I think we do prostate cancer kind of, one of the best countries in the world. The American system is very geared up for treating everybody, whereas in the UK, I think we're much better at working out who does and who doesn't need treatment. So this is the stage that we're at, and we get when we've got the diagnostics done, and we go to what's called a multidisciplinary meeting, and I do that at Guy's, and I would do that like we did this morning at the prostate centre privately. It's exactly the same. A group of surgeons, radiation doctors, pathologists, and radiologists, and they would do this for breast cancer, colorectal cancer. This is how the NHS does stuff. We come together with a grade and a stage, and we work out who needs what treatment based on those things, and importantly, obviously, the age of the patient and how fit they are. Because, as I said, if you're very elderly and very unfit, then you're not going to be suitable for some of the more involved treatments. And the treatment for options for prostate cancer, and this is kind of one of the challenges of it, it's one of the joys of it, it's also one of the frustrations of it, is that men feel they need to do a sort of A-level in prostate cancer sometimes before they can work out what's best to be done. And we're very good at giving people options. I would say perhaps less good at telling people what they should do sometimes. So I will not sit on the fence. If I think you're better off with radiotherapy, I would tell you. And if I think you're going to do really well with an operation, I would tell you. And sometimes you say, well, for you, it's arguable. So active surveillance means there's not much cancer there. We don't think it's a risk to you right now. We're going to survey you with MRI scans, PSA tests, and maybe do another biopsy. And if it gets worse, we're going to treat you with a view to curing you at that stage. Now, that's very different to lots of other tumor groups where we'd call it watchful waiting, where we say we're not going to do anything, but then we'll kind of palliate you with some medical treatment when it gets worse. Active surveillance, we want to cure you, but only if it's shows that the cancer's getting more aggressive. Brachytherapy is placing small radioactive seeds in the prostate, very elegant way of treating prostate cancer, but a relatively small group of men who are suitable. You need a small prostate, no urinary symptoms, no previous radiotherapy. There are some rules. And we've got surgery and radiation, which are the two main modalities. Surgery in this country now is 92% robotic surgery, which is kind of amazing. That 20 years ago it was 0, and 10 years ago it was about 10%, and now it is literally 92%. So that's keyhole robotic surgery. I'll show you a video. You don't have to watch. And radiotherapy treatment, which is giving men a combination of hormones to shrink the prostate and kind of prepare it for the radiotherapy, which is a male testosterone blocking hormone. And then a course of radiotherapy, which used to be 6 weeks, now is 4 weeks. Some other types of therapy they're trying to do within a week. Emerging therapy, some people may have heard of, which is things like HIFU and cryotherapy, which haven't yet got sort of what we call NICE approval, as in they're not standard, but they seem very effective in suitable men who have just perhaps one tiny, obvious and visible area of cancer. So if you have a quarter of the prostate involved with cancer that you can see, then some men do very well with those. And sadly, for the men who present at a later stage, it really is a question still of starting them on the hormones, which is a sort of form of chemical castration, which is an awful word, but that is kind of the medical word for it. And then some chemotherapy type agents orally nowadays, rather than intravenous. So we've made some progress on those in COVID actually, and got some new sort of legislation through. Now this is a robotic prostatectomy. I hope this will work. Yeah. So this is looking inside somebody's pelvis. So the prostate is at the top of the screen. There's the pubic arch, like a sort of over the top. Bladder is at the bottom. And this is a man with Gleason 3+4, which is probably the commonest type of cancer, which means a medium risk cancer. It's staged as being contained in the prostate. And this operation happens about 10,000 times a year in the UK. And probably there's about 15,000 times a year we do radiotherapy, something like that. Because radiotherapy can be given to slightly older and less fit men. So once the prostate and the bladder have been kind of divided, this is at the back of the prostate. We then find these are the sperm tubes. You don't have to watch all of this, but I'll just show you a couple of bits. Why do it robot? Because it's very, very replicatable. The standard has gone absolutely really up through the roof since we started doing it this way. Most men are in hospital only for a day, go home the next day with small scars, and you get this amazing view underneath where you can really see each little sort of layer of tissue around the prostate. And the prostate's a bit like an onion in that it's got multiple layers. And this is where the money's at, which is trying to peel away the nerves, which is this kind of web of stuff on the right. Those nerves contain the erection nerves. So if you think the cancer's all contained, then you peel away the nerves for the erection, and that's with the right, this is the left. And the idea is that you then preserve those nerves such that men can regain, not in all cases, but in many cases now, regain potency, either with or without something like Viagra or mini Viagras, to try and help them in the recovery. Because we want to get all three things right for a man going into this, which is all the cancer out, fully continent, and preserving the nerves. And obviously, if you're a 60-year-old businessman who plays tennis every week or golf, and you've not smoked and you're not obese, then the chances of that are much higher than if you're not any of those things. So you can only deal with what you're given, but you know, the results of this are increasingly good in centres that do a lot of it. Anyway, so that is a bit gory. That's just the end part. I'll show you this. And the other reason the robot is great is that we do this very delicate suturing, and the dexterity of the robot really allows you to do the suturing in a very nice way. So this is just showing you sort of how the robot arms move. And this is primarily started its life in the prostate, but I do a load of kidney operations with this now. We do bladder operations, testis operations, and this is being rolled out to gynae, general surgery, GI, thoracics, the lot. So the whole of minimally invasive laparoscopic surgery, in my opinion, is kind of going to go this way in the next few years. Anyway, you get the idea there. That is keyhole surgery. So just moving on from prostate cancer, because we'll link these back together. These are two diagrams of a normal prostate and an enlarged prostate from the side view. And you will see that in the left diagram, the urine has got a great big pipe that can come through because maybe that person's 30 years old and they're standing next to you at the urinal and they're absolutely got a great flow. And then in the one on the right, of course, the urine's slightly getting sort of turned back, only a small amount's going through because the prostate is enlarged and it's squeezing that urethra pipe. So this is one of our sort of slightly nerdy urology things. We say LUTs, which means lower urinary tract symptoms, don't always equal enlargement of the prostate, but they do a lot. So for us, we've got symptoms, usually means an enlarged prostate. It usually doesn't mean cancer unless the cancer is particularly bad. And usually it means BOO, means bladder outflow obstruction, which means usually if you have problems urinating and you have an enlarged prostate, normally the prostate's causing a blockage. It's not rocket science. You know, those things all kind of go together. But as we alluded to, and as Brian said, you know, the rates of urinary symptoms for men with an enlarged prostate really go up as men get older. So, you know, when you're in your 50s, you know, there's about almost a 50-50. You've got some mild urinary symptoms and about a 40% chance you've got some moderate urinary symptoms. And as you can see, the sort of moderate curves go up, the severe curves go up as men get older. We also remember that you need to probably, it's good to see a urologist because there's a whole lot of other stuff that can also give you urinary symptoms. You know, someone getting up 5 times a night, it might be because they have diabetes. It might be because they've got restless legs. It might be because they've got other cardiac issues, that meaning they're offloading a lot of fluid. So it's not all as simple as just taking a history of how people are with their waterworks. And this, again, is a good example of why you can't run medicine on the phone, and a Zoom call doesn't always suffice because you need to get in and see people to do a lot of this assessment. So the symptoms that we are talking about are symptoms of what's called voiding. So there's 2 types of urinary symptoms. None of you would ever thought about this, but this is what we teach our junior doctors. So voiding symptoms, which is basically can't start, can't go, can't stop. So if you have that, that's quite likely to be due to an enlarged prostate. So that's poor flow, intermittent scream, hesitancy, straining, and dribbling a bit at the end. And then the other type of symptoms, which I think of is when I'm teaching people, it's like perhaps a woman with a urine infection, where the bladder's become very, very sensitive, which is urgency, maybe urge incontinence because you don't get there, frequency of avoiding, and nocturia, which means getting up at night. Now, of course, unfortunately, the bladder is said to be an unreliable witness, which is just by speaking to people, you can't always tell, because often people have a bit of both. Because once the prostate gets big, the bladder gets more sensitive, and so men often get up a lot at night, often have some urgency, and often then also have some slow flow and incomplete emptying. But interestingly, it's the storage symptoms that really bother men. To be honest, no one cares if they spend an extra 10 seconds going for a week. What they care about is getting up 4 times a night, and the wife cares about getting up 4 times a night, or the partner, because they're not getting any sleep and rushing off every 5 minutes in a meeting. So those are the ones that are actually more impactful on your quality of life. So as well as the PSA test, what do we do if men come with symptoms? Well, we get them to fill in one of these little international prostate symptom scores. We examine them, we do a volume chart, see how much they're weeing, how much they're drinking. We might take their kidney function, we do a urine test, and we do an ultrasound scan of the urinary tract to check the kidneys aren't swollen, the bladder looks fine, and measure the size of the prostate. People talk about the prostate being the size of a walnut, but of course, if we're getting into various types of ball here, we can go ping pong, golf, clementine, and tennis ball. My sort of special area is more of a tennis ball variety and doing laser surgery for men with huge prostates. But that's why examining a man, you'll get some degree of information from doing that. And the bigger the prostate, the more likely it is to cause problems, although you can have a giant prostate and no problems. So what are the treatment options for an enlarged prostate? Well, they're lifestyle, which means don't get constipated, drink less tea and coffee so you don't irritate the bladder. It means restrict your fluid in the evenings. But the medications then come in, which is taking a tablet to relax the prostate, taking a tablet to shrink the prostate, or taking those 2 tablets together. So that's the kind of preliminary work. And then, of course, if you get to the point where you're so bothered by your symptoms that you want something done, or you sadly completely go into retention, then there are a number of surgical procedures, which used to be just scraping away the prostate with a sort of hot loop, which still happens in about 50% of the country. But this is a video of doing it with a laser. And what this shows is a laser which is end firing, cutting through the prostate tissue, and it's doing what's called, we call enucleation, which means kind of as if your prostate was, say, a satsuma, you know, an orange with a thick skin, and you're basically removing the whole of the inner part of the prostate. So it's called enucleation because every part that can grow back is removed. So this is a very definitive way of doing it. It's quite tricky to learn. I'm very grateful that some legends of urology kind of persevered and taught me this about 15 years ago. And there is the whole middle of the prostate being pushed inside the bladder. So you've got a great big chamber now, and then you sort of hoover all that out with a suction device. So those of you who read the Daily Mail or otherwise informed will have noticed that there's some other things that are on the market as well. There are PAE, which is prostate artery embolization, which is putting beads in. So that's not an operation, it's a procedure in an X-ray department to block the blood vessels to the prostate so it shrinks down. And then the other new procedures are Urolift, which is placing sort of little metal tags to hold the prostate back, or steam therapy, which is actually literally injecting 100-degree plus steam into the prostate, which kills off the part that's causing the blockage. So that can also be done. And there's also a robotic controlled aquablation sort of water jet that is also quite interesting and may have a role. So there's been quite a dynamic area of things arriving. So a few things just to finish. The man with urinary symptoms is usually worried about prostate cancer, but usually doesn't have prostate cancer. The partner's always worried about prostate cancer. And I think often the GP is. So if you do have urinary symptoms, you know, it's fine. Come in, see a urologist and get checked, and we'll do these tests and hopefully reassure you and make a plan. The only way to know that you're okay is to be checked. If you don't come, then you may be sitting on something that isn't enlargement of the prostate, and you know, it may be too late by the time you come. So just get checked, because most of the time it's not prostate cancer. It could be prostatitis, which is infection or inflammation of the prostate. And I don't want to dwell on this too much, but it is a difficult area. So we often see men with acute infections, which is acute prostatitis. But sadly, quite a number of men have persistent relapsing sort of pain from the prostate, which again is best investigated by a urologist, making a treatment plan, using some of these medicines, almost never needs an operation. Start with antibiotics, anti-inflammatories, and some of these prostate meds to relax the prostate are quite good for that. And just to reiterate again, prostate cancer is mainly a disease of older men, over 60 usually, although 50s can often be found. My key messages are, if you're worried or you're an at-risk group, get a PSA. Symptoms usually mean an enlarged prostate, because cancer grows on the outer part and enlargement happens on the inner part. Many men with prostate cancer that have no symptoms at all. So just because you feel fine doesn't mean you're fine. That's a difficult one with this. I'm fine, I've got no symptoms. Well, you've got a family history, you don't want to wait till you have symptoms. Get checked. Effective treatments are available now on the NHS for both prostate cancer and a whole range of things for lower urinary tract symptoms, enlargement of the prostate. And urologists are friendly. Come and see us. We hang around with cool gear and doing cool stuff, and we have a very lovely technology-driven specialty, and it's nice to look after people. So come and see us if you're worried. But thank you very much for your kind attention.
Thanks, Ben. Absolutely fascinating, and unfortunately, probably plenty for me to be thinking about at 4 o'clock tomorrow morning. We've had quite a few questions from the audience, so I've got one here which I'm going to sort of bundle together a little bit. So we saw the age profiles you were talking about for getting tested, but bundled question: what age should I start getting screened? Should I wait until I get symptoms until I request a PSA or other tests from my GP? And how often should I be perhaps going back? If I'm okay this year, should I be going back every 2-3 years? How often?
Yeah, no, thanks, Brian. I mean, they're the key points. So generally, the feeling amongst urologists is that if you're an at-risk group, say you're Afro-Caribbean or you have family history or both, you should be getting checked at 45. If you particularly had cancer that happened very early in your family, then you may want to go with 40, but you don't need to be checked before that. For standard men who don't have risk factors, you can still be checked, but most people would say 50. Depending on your level of PSA at that point, that will give an indication of how many times you need to be checked. So if you turned up and your PSA was 0.4, I'd go, well, you're laughing. It's absolutely tiny. You're at very low risk. You must have a small prostate. There's no, you're nowhere near a worry level for cancer. So maybe come back in 3 to 5 years. But say you were, your PSA level was 2.8, and I'd say, well, you're probably someone we should keep an eye on and check next year. So I think the GPs have a bit of handle on that, because they can look this up with their charts and look at the referral guidelines, because sometimes a quick rise, even though it's starting from a low point, will also be a trigger for a referral. And often GPs will examine men and find if they found a nodule on the prostate, they'll refer them in, sometimes if the PSA is even within the level. So I say, if you're worried about your prostate health and you have any symptoms, then it is sensible to get checked almost at whatever age you are.
Okay. And Ben, what are the sort of biggest causes? I mean, age seems to be a real predicator, but are there any other causes, the lifestyle things that, our nutrition, any other factors apart from ethnicity that raise prostate issues?
So when you do trials on this, of course, Brian, it's quite difficult to do it, because you can't put 100,000 men with a set diet and then get another 100,000 men with another diet. So the data tends to be what's called retrospective studies, where people do questionnaires basically about a whole load of men who do and don't, and they kind of try and extrapolate. So the data is not strong, but generally we think that a diet with lots of fruit and vegetables is protective. We think that red meat, and particularly cooked red meat, is bad, and that literally goes back to sort of the fact that the only other animal that gets prostate cancer is a dog, and they think that maybe the dogs ate meat from the caveman's barbecue 100,000 years ago, and that might be some sort of link between red meat. We know that say, Japanese men who have a very low risk of prostate cancer in Japan, if they come and live in California, within one generation, they develop the same risk as white Californian men, even though they're at the same, longitude, latitude. So it's not to do with climate. That must be to do with environmental factors, and therefore it must be to do with a Western diet. So obviously people ask about this all the time. We think being well hydrated is good because you're going to get less inflammation. We know a lot of cancers are caused by inflammatory processes, whether that be sunlight or reflux in the bowels or in the nasal polyps. So actually, bizarrely, there's a study. I don't know how they got consent for this. This will probably be the only thing anybody remembers. But if you ejaculate 12 times a month, you're meant to be protected. So that's one that no one's ever sad when I tell them that piece of data. But again, it goes along the lines of not getting urine infections, not getting stagnation of urine. But I think sensible Mediterranean diet, plenty of tomatoes, lycopene's meant to be good. And I read a study once that said that Pinot Noir was the best wine for prostate cancer, but I haven't done extensive research on that yet. But I'm looking forward to it at some point.
Okay. And clearly, there's been quite a lot of good developments over the last few years coming through, including the use of the robotic surgery, Da Vinci robot, etc. What's coming? What are the next developments for perhaps screening and treatment of prostate cancer?
Well, we're very privileged in the UK that we've run most of the practice-changing trials in things like MRI within London in the last 10 years. Our colleagues at UCH have been fantastic at proving how useful MRI is and how we can now do some of these more focal therapies. But we're going to be better at doing individualized medicine, which means that we don't just take a biopsy and look at the cells, we take a biopsy and look at the genetics, and we can really try and get beyond just saying, oh, it's a Gleason 3+4, therefore we should treat you. We think there must be a way that they can say, hang on, it's a Gleason 3+4, but you're probably okay. Or it's a Gleason 3+4, but it's going to turn nasty in a couple of years, so you need treatment. So individually stratifying people's risks is going to be key. We're the best country in the world at not treating people, which sounds a bit funny, but America, was just taking out every man's prostate in the 1990s with tiny amounts of cancer. And we put it up each year and the Americans can't believe it, that we're literally 4% of men with low risk cancer in this country get treated. Everybody else gets monitored. So we're very good at working out who does and who doesn't need treatment. And of course, the robotics has meant that we've moved into, instead of like 400 people doing 5 ops a year, there are now about 50 people doing 200 ops a year. And that centralization, along with the increase in technology, say for robotics and the advances in radiotherapy in the big centers, I think has all helped us treat men in a much more elegant way. We're better looking at our outcomes. People who aren't any good stop doing it, and so that across the country, our quality across the board has gone up.
Okay. Question that's just come in. So, does having a vasectomy or having had a vasectomy affect the PSA test results?
We don't think it affects the PSA test result because, it's not the sperms that make the PSA go up, it's the process of ejaculation. But what somebody may be alluding to is there was a study showing that if you had a vasectomy, you were more likely to have prostate cancer. And of course, bizarrely, that is true, but not because one is the cause of another. We're absolutely sure that there's no risk to getting prostate cancer from a vasectomy, but the sort of men who are health aware, the sort of men who want to take control of their own birth control are the sort of men who are going to get checked, and therefore you will be case finding more men. So I'm afraid it is part of being a thoughtful individual. I think that if you get a vasectomy, you're slightly higher risk of getting prostate cancer diagnosed because you're more likely to get checked.
Okay. Ben, clearly we've got a lot of employers who are listening today. What do you think that they can be doing to help their employees with regards to sort of improving prostate awareness amongst the staff?
Well, I mean, that's the key thing, is that it's very easy, and of course lockdown has shown this. You saw the graph with the fact that that as across South London where I work, we've only got 50% of as many men with prostate cancer as we had last year. the year before. I mean, so COVID has not cured those men. They're just not coming forward. It's still there, and we know that there is going to be this big upsurge. So I think if you're in an at-risk group, you need to get checked. I mean, that is the men are not good at coming forward. I just say that myself. I have appointments, and we're just not good at it. And we need, our partners, our wives and girlfriends, boyfriends, to be, to be talking about this stuff, to be going and getting checked, because that PSA test and the subsequent MRI scan, it may just save your life. So I think it's just encouraging men, if they're worried, get checked. If you have symptoms, get checked.
And if you've got people who are coming to you who've got concerns, they may be on the wait and see list, they may be having some treatment, clearly that's going to affect their own mental health and well-being. Do you recommend any particular support for people who are going through this sort of treatment?
In terms of the support, everybody with diagnosis of prostate cancer, or indeed any cancer, should have what's called a clinical nurse specialist in the NHS, and they would get that NHS and privately now. And that within that are linked to sort of Macmillan counsellors. Most big centres also have a kind of a patient group that do meetings. So that the active surveillance group would have a regular meeting, and of course with Zooms and Teams, that's really useful. For some men, it will hit them really hard, obviously harder than others. And so we need to be, I suppose, we're trained to try and pick that up, to be aware of that, and to offer additional counselling to men, because obviously this is all tied up with virility, with sexuality, with libido. It's all linked to this. So it's not, for me, that's the challenge of prostate cancer. It's not just the same as taking out, a piece of bowel or a kidney. That don't have those. They have some technical issues, but they don't have those kind of intimate issues. Those, and we know that also men with partners do generally better than men who are on their own. And that's a big red flag for me. If I see someone repeatedly coming up on their own, that I would make active efforts to try and get hold of their GP, try and find out who could support them, try and plug them into one of our support groups and counsellors.
Okay, Ben, before we finish, any sort of final key messages or takeaways that you'd like to give the audience today?
Well, I deliberately tried to hit them a couple of times in the talk, but I mean that's what it's at, which is it's just the commonest male cancer. It's really the commonest lethal cancer for men. All men have a prostate. All men will have a PSA that can be measured. If you're fit and healthy and you're worried about dying of prostate cancer, then you should get checked. And if you have symptoms, in the most part, it's not prostate cancer, but it could be quite bad prostate cancer. So in that situation, get checked, because you're probably going to be reassured, and the doctor can probably give you something that's going to improve your quality of life and put your mind at rest.
Okay. Ben, I think our sort of 45 minutes is nearly up. I just want to say thank you for a cracking presentation, some really interesting and particularly useful information that I think we all need to be aware of, so that we can hopefully keep fit and healthy. And I think it's important to know what symptoms are and what we should be doing about it, which sounds to me that the sort of picking up the phone to getting in to see a GP in the first instance. What we're going to be doing, we will be circulating the recording and a write-up of the webinar and sending it out to everyone in the next week or so. I'm particularly grateful to Ben for his time and incisive thoughts and information. Thank you all to you for coming, and I hope you've found the webinar as interesting and useful as I have. Thank you very much indeed. Have an enjoyable rest of your afternoon.